Let's talk about gastroesophageal reflux disease. So, gastroesophageal reflux disease is a serious form of gastroesophageal reflux which occurs when the lower esophageal sphincter opens spontaneously or does not close properly, and stomach contents rise up into the esophagus. So, we know that the esophagus is a muscular tube which is 20 centimeter long, and it connects the pharynx to the stomach. So it has two sphincter. We have the first sphincter, which is called the upper esophageal sphincter, and we have the lower esophageal sphincter, which is at the level of the diaphragm. So this sphincter opens when someone swallows food, and it closes most of the time to prevent the rising up of the content of the stomach. But in this condition, we have this sphincter fails to close properly, or it spontaneously open, causing the contents of the stomach rising up back into the esophagus. And we know that the contents of the stomach is acidic, so that acid will cause erosion and inflammation of the esophagus. So that is what we call gastroesophageal reflux disease. So the clinical features of gastroesophageal reflux disease, we have one, heartburn, which is the cardinal clinical feature, and this is explained by the patient by saying it is a burning sensation in the chest or in the stomach. And then apart from that, we have regurgitation. So regurgitation of food and acid into the mouth. Okay, this is mostly severe when the patient bends or lie flat. Okay, so that is the contents will easily rise up into the esophagus when you bend or lie flat. That's why this is exacerbated by bending or lying flat. Then apart from that, we have epigastric or chest pain. So the patient will come complaining of chest pain, and it is very important to differentiate this chest pain from the one which is experienced in cardiac ischemic pain, okay, or in MI, which is myocardial infarction. So that pain should be differentiated from this one, which is felt in gastroesophageal reflux disease. And apart from those these clinical features, we have extraesophageal manifestations. These manifestations comes about due to the contents reaching the pharynx and the larynx. So in a condition which is called laryngopharyngeal reflux disease, where we have the acidic content affecting the larynx and the pharynx, causing the inflammation of the larynx and the pharynx. So this is represented by cough, hoarse voice, post-nasal drip, and asthma symptoms. Okay, so talking about the pain, the chest pain, which is felt in gastroesophageal reflux disease. Now, how we can differentiate it from the one which is felt in cardiac ischemic pain. So the one which is felt in myocardial infarction or in angina. So the reflux pain is burning, and it is worse on bending, stepping, or lying down. Okay, so it is burning, worse on bending and stepping or lying down. And then it rarely radiates to the arm. But for cardiac ischemic pain, it is gripping or crushing, and it radiates to the neck or left arm. Then from there, the reflux pain is worse with spicy food, hot drinks, or alcohol. So the patient will explain to say, when I drink alcohol or when I drink hot foods or I drink hot things, the pain worsens. Okay, and then apart from that, it is relieved by antacids. But for the cardiac ischemic pain, it is worth with exercise. So the patient will say, when I do exercise or I do certain work, the pain will be worse, and it is mostly accompanied by dyspnea, which is difficulties in breathing. So that's how we can differentiate the reflux pain from the cardiac ischemic pain. So the risk factors for gastroesophageal reflux disease, we have one, pregnancy or obesity. So pregnancy, we know it increases the pressure in the abdomen, so that will cause increased pressure can cause reflux of stomach content. Then apart from that, we have fat, chocolate, coffee, or alcohol ingestion as one of the risk factors. Then large meals, so taking a lot of things like it will extend, large meals will extend the stomach, will increase the pressure inside there, and it can easily cause rise up of contents into the esophagus. Then we have cigarette smoking. Then apart from that, we have drugs such as antimuscarinic drugs and calcium channel blockers. So these drugs will cause relaxation of smooth muscles, so that will also affect the lower esophageal sphincter, because it is comprised of muscles which contract to keep the sphincter closed. So if you take antimuscarinic drugs or calcium channel blockers, they will relax the sphincter, and that will cause the rise up of the stomach content. Then another risk factor, we have systemic sclerosis, and we also have treatment for achalasia. So achalasia, the lower esophageal sphincter is failing to open. So when you treat that condition, it will cause relaxation of the lower esophageal sphincter, since in achalasia that's the problem. So when you relax the lower esophageal sphincter, there is a chance that the stomach contents will rise up into the esophagus and cause the gastroesophageal reflux disease. And hiatus hernia is also one of the factors, one of the risk factors. So hiatus hernia is a risk factor. Why? Because in hiatus hernia, we have the herniation of the stomach into the chest. Okay, so it passes the cruller of the diaphragm, and now the lower esophageal sphincters rise up into the chest. So the sphincter is held closed by the help of the smooth muscles of the sphincter, as well as the cruller of the diaphragm. So the cruller of the diaphragm here also helps compress the sphincter there to keep it closed. So in hiatus hernia, we have herniation of the stomach back into the chest, and that will now misplace the sphincter. Instead of the cruller of the diaphragm pressing on the sphincter, we have the cruller placing on the stomach, and now the sphincter will be weak, and that will lead to rising up of the content of the stomach. That's why hiatus hernia here is one of the risk factors. And in most cases, gastroesophageal reflux disease is associated with hiatus hernia in those who are above 50 years of age. Okay, so diagnosis and investigation. So mostly diagnosis is clinical. We just look at the clinical features and we start treating the patient. But if we have alarming signs, more especially dysphagia, then we will also do further investigations, such as assess esophagitis and hiatal hernia by endoscopy. So we'll do the endoscopy of the endoscopy to assess the esophagitis and hiatal hernia. So once we confirm reflux. We confirm reflux if there is esophagitis, inflammation of the esophagus, or Barrett's esophagus. So this is the severe form. esophagitis. So if we confirm these two using an endoscopy, then we confirm that there is a reflux of the content of the stomach. Then apart from assessing esophagitis and hiatal hernia by endoscopy, we can also do an intraluminal monitoring. So in this case, we are monitoring pH monitoring. So if the pH is lower than 4 in the esophagus, then we can say there is a reflux. So this is done in two ways. We have what we call the ambulatory 24-hour pH monitoring. So this is done by inserting an NG nasogastric tube with a pH probe. So there is a probe there which is connected to the NG tube, and then we insert it at the level of lower esophageal sphincter, okay, and then we allow the measurement of acid, and this is done for 24 hours. So after 24 hours, we remove and check the pH, okay. So this pH probe is inserted at the tip. It's placed at the tip of the ND tube and placed at the level of lower esophageal sphincter. Then after 24 hours, we check the pH. If it is lower than 4, then we know that there is a reflux. Okay. Then apart from that, we can also do another investigation under intraluminal monitoring, which is called the Bravo capsule. So the Bravo capsule is a wireless probe. So this pH probe here is connected to the NG tube, but this one is a wireless. So it is clipped at the lower esophagus without the need of the NG tube. Then after some time, it will be passed in the stool, and a composite score is measured. Okay, so the calculations will be made and the score will be done, and then that composite score, if it is higher than 14.72, then that will indicate reflux, and that score which is higher than 14.72 is known as the Demister score. So those are some of the investigations which can be done. So remember, investigations are done when we have an alarming sign, okay, such as dysphagia. But in most cases, it is clinically diagnosed. So we just look at the clinical features, and then we start managing the condition. But otherwise, if there is an alarming sign, then we will go further and do these other investigations. So apart from that, esophagitis can be classified using the Los Angeles classification of esophagitis, which are in 4 grades. So we have grade A, grade B, grade C, and grade D. So in grade A, the esophagitis is less than 5 millimeter, is equal to or less than 5 millimeter, and they are just confined into the folds, within the folds. In here, they are not crossing the top of the folds, so they're just within the fold, and the lesions are less than 5 millimeter. And in grade B, the lesions are, or the breaks are greater than 5 millimeter, and they do not cross the upper part of the folds. So they're just consigned in the folds, but they are not crossing the folds, and they are greater than 5 millimeters. But in grade C, we have these breaks. Now they are crossing the tops of the folds, but they are not completing the circumference of the esophagus. Okay, so they are crossing the top of the folds. So remember, we have these 2 folds here, and then the lesion here has crossed the folds, but it is not affecting the whole circumference of the esophagus. But in grade D, we have now these breaks are now crossing the top parts of the folds of the esophagus. We have the folds here, then the lesions are crossing the folds, and then they are affecting the whole circumference, the circumference of the esophagus. That is the grade D of esophagitis. Okay. So now, management. How can we manage gastroesophageal reflux disease? So management, in most cases, we just use simple antacids, and then apart from that, we would advise the patient to lose some weight, and when sleeping, at least raise the head of the bed at night, so to prevent the reflux. We know the lower esophageal sphincter is spontaneously opening, or is not closing properly. So raising the head of the bed at night will help prevent the rising up of the stomach content. And then apart from that, we can also try to avoid precipitating factors, which with dietary measures. So we avoid taking citrus fruits, chocolate, onion, and garlic or spicy foods, and among others. So avoid taking these foods will also help manage the condition. And then apart from that, we also, a patient needs to avoid alcohol and caffeine consumption, and cessation of smoking. Okay, so that is how we can manage. Apart from that, we can manage this condition using drugs. So the drugs which are mostly used, what we call the antacids. So the ogenate containing antacids are used, and they are taken 10 mils 3 times a day daily. Okay, and mostly they are mostly frequent used over the counter agents for gastroesophageal reflux disease. So these antacids, which contain ogenate, they form a gel. They form a gel or a foam raft with the gastric content to reduce the reflux. So they will form a gel, okay, so which will hold some of most of the gastric contents to prevent the reflux. Okay, and then the antacids which contain magnesium mostly cause diarrhea, so you must take note of that. And then those which contain aluminium, in most cases they cause constipation. Okay, so apart from antacids, we have proton pump inhibitors. Okay, so we have proton pump inhibitors. So proton pump inhibitors such as omeprazole and lansoprazole are also used in gastroesophageal reflux disease. Then apart from that, we have H2 antihistamine agonists are also used in gastroesophageal reflux disease. So thank you so much for watching. Don't forget to like, subscribe, and leave a comment in the comment section below.